Everything you think you know about Ozempic might be based on a lie. Let me show you the truth. Here's the problem. GLP-1 medications, Ozempic, Wegovy, Mounjaro, Zepbound, became the most talked about drugs on the internet before most people understood how they actually work. And when a topic gets that big that fast, misinformation fills the gap. I'm a registered nurse. I'm not here to sell you anything or to talk you into or out of anything. I'm here to do what I do at the bedside every day. Separate what the evidence actually says from what a scary headline wants you to believe. Because this isn't harmless. When people believe a myth, they make decisions out of fear instead of facts. Someone who could genuinely benefit avoids treatment because of a rumor. Someone else stops their medication overnight because of a TikTok. Both can be dangerous. So today we're busting 7 of the biggest GLP-1 myths, and for each one, I'll show you the myth, why so many people believe it, what the clinical evidence really says, and then the nurse's verdict. Let's get into it. Myth number 1, and probably the scariest one. GLP-1s cause thyroid cancer. This one has a kernel of truth, which is exactly why it spreads. These medications carry a boxed warning, the FDA's strongest, about thyroid tumors. So people see boxed warning plus cancer and understandably panic. But here's what the warning is actually based on. Studies in rats and mice given high doses over their entire lifetimes who developed a specific thyroid tumor. Rodents have far more of the receptor these drugs target in their thyroid than humans do. So what happens in a rat at massive doses doesn't automatically happen in a person. And when researchers actually studied humans, the picture got reassuring. A large 2025 international study pooling 6 national databases across multiple countries found no increased risk of thyroid cancer in GLP-1 users. Multiple large trial meta-analyses landed in the same place. No statistically significant increase. A couple of studies have flagged a weak possible signal, so this isn't case closed forever. But the strongest human data we have does not show these drugs causing thyroid cancer. Nurse's verdict? The rodent-based warning is real and worth respecting, which is why these drugs are not prescribed to people with a personal or family history of medullary thyroid cancer, or the genetic condition MEN2. If that's you, this matters. But for the general population, Ozempic gives you thyroid cancer is not what the human evidence shows. Know your family history, tell your provider, and let them screen you properly. Myth number 2. You gain all the weight back the second you stop. People believe this because there's real data behind the headline. In studies, when participants stopped the medication, many did regain a meaningful portion of the weight over the following year. So the myth isn't invented, it's just told without the context that changes everything. Here's the context. Obesity is a chronic, relapsing medical condition. It behaves like high blood pressure or high cholesterol. Nobody is shocked when blood pressure climbs back up after someone stops their blood pressure pill. We don't call that pill a failure. We understand it was managing a chronic condition, not curing it. GLP-1s work the same way. The weight returns for some people because the underlying biology returns, not because the medication didn't really work. And the regain isn't automatic or total for everyone. People who pair treatment with sustainable nutrition, strength training, and protein tend to hold their results far better. Verdict: you gain it all back is misleading. A more honest version is, it's a long-term tool for a long-term condition, and stopping abruptly without a plan is what sets people up to regain. Whether someone stays on it, tapers, or transitions to other strategies is a real medical conversation with a provider, not a comment section. Myth 3 isn't really medical, it's moral. using a medication is cheating. It's the easy way out. This belief comes from a deep, old assumption that body weight is purely about willpower and that anyone who uses help just didn't try hard enough. It feels intuitive. It's also wrong, and it's the kind of weight bias that keeps people from getting care. Body weight is regulated by biology, hormones, genetics, the brain's appetite and reward circuitry, sleep, medications, medical conditions. For a lot of people, that system is set up to defend a higher weight and to fight back hard against loss with intense hunger signals. GLP-1 medications work on that biology. We don't tell people with diabetes that insulin is cheating. We don't tell people with depression that their medication is the easy way out. Using an evidence-based tool for a medical condition isn't cheating, it's treatment. Verdict: there is no easy way out here. People on these medications still have to eat well, move, manage side effects, and do the work. But even if it were easier isn't cheating. We don't make people suffer for the sake of suffering in any other area of medicine, and we shouldn't start here. Myth 4. These drugs permanently wreck your metabolism. You'll never be the same. People feel something real and then explain it wrong. When you lose a significant amount of weight, by any method, your body burns somewhat fewer calories at the new, lower weight. People notice that and conclude the drug broke them. What they're describing has a name: metabolic adaptation. A smaller body needs less fuel, and your body also defends against weight loss by dialing energy use down a bit. This happens with dieting, with surgery, with any weight loss. It is not unique to GLP-1s, and it is not destruction. It's biology doing what it's designed to do. The real, evidence-based concern with rapid weight loss is losing muscle along with fat, and that's manageable. Adequate protein and resistance training protect lean mass and keep your metabolism humming. Verdict: GLP-1s don't destroy your metabolism. Weight loss adapts it, like it always has. The fix isn't fear. It's protein, resistance training, and not crash losing. That's a plan you build with your provider, not a reason to panic.
Myth 5. These are diabetes drugs. Using them for anything else is off-label and sketchy. This made sense a few years ago because the very first version, Ozempic, was approved for type 2 diabetes. People anchored to that and never updated. But the science and the approvals moved fast. Same active ingredient, different brand, different FDA-approved purpose. Semaglutide is sold as Ozempic for type 2 diabetes, and as Wegovy, which is specifically FDA-approved for chronic weight management in people with obesity or overweight with a related condition. It doesn't stop there. Wegovy is also approved to reduce the risk of major cardiovascular events, heart attack and stroke, in certain adults, and for a serious fatty liver condition with scarring. There's now even an oral semaglutide pill approved for weight management. These aren't fringe off-label uses. They're studied, FDA-approved indications. Verdict: only for diabetics is simply out of date. These medications are approved across several conditions, and which brand and dose fits which person is exactly what a prescriber sorts out. The drug class outgrew the rumor. Myth 6. If you take these, it's basically a matter of time before you get pancreatitis. Pancreatitis is listed as a potential serious side effect, so it's not made up. And early on, some studies hinted at a possible signal. Add a few dramatic personal stories online, and rare risk gets rounded up to happens to everyone. So what do the actual numbers say? A 2026 review pooling 31 placebo-controlled trials, more than 40,000 patients, found no increased risk of acute pancreatitis compared to placebo. The rates were essentially identical between the medication and the dummy injection. In a major weight loss trial, pancreatitis showed up in roughly 3 out of over 1,300 people on semaglutide. Even in higher risk groups, we're talking low single-digit percentages. Not everyone. Verdict: pancreatitis is a rare and serious risk worth knowing, not a guaranteed outcome. The smart move isn't fear, it's awareness. Know the warning sign: severe, persistent belly pain that may radiate to your back, often with nausea or vomiting. And if that happens, stop and get medical care. That's not a reason to avoid treatment. That's just being an informed patient. Myth 7. And this one's sneaky because it sounds reasonable. It's basically just an expensive appetite pill that makes you eat less. The most obvious effect is reduced appetite, so people assume that's the whole story. But that's like saying a smartphone is just a fancy phone. The visible part is the smallest part. GLP-1 is a hormone your own body already makes after you eat. These medications mimic it, and it acts in several places at once. It signals fullness in the brain, yes, but it also slows how fast your stomach empties, so you feel satisfied longer. It prompts the pancreas to release insulin when your blood sugar is actually high, which is why it helps diabetes. It tells the liver to dump less sugar into the blood, and the newer dual-action medications hit a second hormone pathway on top of that. This multi-target action is also why these drugs show benefits beyond weight, like the heart and kidney effects we keep seeing in trials. Verdict: calling it just an appetite suppressant badly undersells it. It's a hormone-based metabolic medication that happens to also reduce appetite. Understanding that is the difference between using it wisely and misunderstanding it completely. Now, here's the most valuable part, because new myths will keep coming, and I want you equipped. 5 questions to run any GLP-1 claim through. 1. Who's saying it, and what do they get out of it? A scary claim attached to a product they're selling you instead is a red flag. 2. Is it a rat study or a human study? Caused tumors in mice at huge doses and causes cancer in people are not the same sentence. Watch for that swap. 3. One story or a pattern? A single dramatic anecdote is not data. Ask what happens across thousands of people, not one viral video. 4. Does it confuse rare with common? A listed side effect isn't a guaranteed one. Look for the actual rate. 5. Can you trace it to a real source? Major medical organizations, the FDA label, peer-reviewed research. If a claim evaporates the moment you look for the source, treat it that way. Run claims through that filter and you'll catch most misinformation before it scares you out of, or into, a decision. If even one of these surprised you, here's the most helpful thing you can do. Share this video with someone who's confused, scared, or being judged about GLP-1s. Fighting misinformation is a team sport, and you just became part of the team. Then, tell me in the comments, what GLP-1 myth have you heard that you want me to fact-check next? I read these, and your question could be the next episode. And subscribe, because I break down the science behind these medications in plain English, from a nurse who actually cares whether you understand your own body. Remember, this channel gives you the facts, but it can't replace your provider who knows your history. Get informed here, make decisions there. I'll see you in the next one. Stay curious, and don't let a headline make your medical decisions for you.